So, hello friends, let's move to the next video of blood pharmacology, that is your anticoagulants. In our previous video, we have discussed about antiplatelet drugs. Now, in this particular video, we are going to discuss about anticoagulant drug. So, let's start with this. So, first coming to the uses of this anticoagulant, where we can use this anticoagulant drugs. So, let's use the highlighter for better view. Okay, so first, in cases of blood stasis, you can use these anticoagulants to prevent your deep venous thrombosis, or in treatment of deep venous thrombosis, in treatment of pulmonary embolism, because deep venous thrombosis leads to pulmonary embolism. Clear? And it is given generally after knee or hip surgery, or surgically ill patient, or in ICU patient, because there is increased risk of thrombosis in this type of patients. Now, second, you can use this drug in DIC, that is disseminated intravascular coagulation. And you are knowing DIC causes varies. Sepsis induced DIC may be there, cancer induced thrombosis, catheter induced thrombosis, then amniotic fluid embolism, then prosthetic heart valves induced thrombosis. These all can lead to thrombosis. Okay, this all will lead to thrombosis. So for all these four, that is sepsis, cancer induced, catheter induced, and amniotic fluid embolism. For all these, drug of choice will be IV heparin, high molecular weight heparin we generally give. And for this prosthetic heart valve, drug of choice will be warfarin. Clear? Now coming to the drugs. So suppose this is the general mechanism, that is clotting factor 10, which is activated, then thrombin, then fibrin formation takes place, all are knowing. So we can use first, that is vitamin K antagonist, which is given through oral route. Then we can use factor 10A inhibitors, which is also given through oral route. Then we can use direct thrombin inhibitors, and this direct thrombin inhibitor is available both orally or can be given parenterally. Then we can use indirect thrombin inhibitors, which are given through parenteral route. So let's start with the first group of drug, that is oral anticoagulant. And this oral anticoagulant is again divided into three groups. The first one is your vitamin K antagonist, the second one is your factor 10A inhibitor, and the third one is your direct thrombin antagonist. Okay, so the first one is your vitamin K antagonist, the second one is your factor 10A inhibitors, and the third one is direct thrombin antagonist. So these are the three categories of the drug which we are going to discuss here in oral anticoagulant. Then we will discuss parenteral. Now, in vitamin K antagonist, the most important is warfarin, and we will concentrate mainly on warfarin. Then it also includes acetylcoumarins, bis-hydroxycoumarins. These are the other drugs which are coming under vitamin K antagonist. Warfarin, acetylcoumarin, bis-hydroxycoumarin. Then factor 10A inhibitor. So 10A. So all the drugs have 10A, such as apixaban. Okay, you will get rivaroxaban. See here, apixaban, rivaroxaban, then edoxaban, then retixaban. Clear? Now coming to the direct thrombin antagonist, which are giving orally. So it includes dabigatran. Dabigatran is direct thrombin antagonist. Now coming to the clotting factors, which basically it will inhibit. So vitamin K antagonist inhibit 2, 7, 9, 10. Factor 10A will inhibit 10, and direct thrombin will decrease 2. Action of 2. Clear? Now moving to the individual drugs, the first coming to the vitamin K antagonist, and in that we will mainly concentrate on warfarin. Okay, we will mainly concentrate on warfarin. So let's start the mechanism of warfarin. So what is the mechanism of warfarin? Let's discuss that first. So it will inhibit VCOR C1 enzyme in liver. Okay, and that will basically inhibit gamma decarboxylation at glutamate residues, because factor 2, 7, okay, factor 2, 7, 9, 10, along with protein C and S, okay, they all have glutamate residues. And at glutamate residue there is gamma carboxylation, and after gamma carboxylation these clotting factors get activated. So if we inhibit gamma carboxylation at glutamate residues, then these clotting factors and these anti-clotting factors will not be activated, clear, is not going to be activated, these clotting factors. So we are inhibiting the enzyme which are responsible for gamma carboxylation, so that gamma carboxylation will be inhibited, so there will decrease synthesis of clotting factor 2, 7, 9, 10 and anti-clotting factor protein C and protein S. This is very important. you have to remember the this also. Along with clotting factor, along with clotting factor, you must have to remember this anti-clotting factors, protein C and protein S. This is the most important silly mistake, okay, that we always forget about this anti-clotting factor. We always remember this factor 2, 7, 9 and 10. So you also have to remember about protein C and S. Now what is the order of deficiency of this factor? So first factor, okay, which is going to be depleted is factor 7. So factor 7 deficiency will be in less than 6 hours, will be seen in less than 6 hours. Then your protein C deficiency, which is going to take place within 8 hours, and last factor which is going to disappear is factor 2. So this is important MCQ question, that which is the first factor which is going to disappear? 7. Last factor 2. Now it means complete anticoagulant effect of warfarin will come within 4 to 5 days, because last factor is disappearing in 4 to 5 days. So complete anticoagulant effect will start coming from 4 to 5 days. Clear? So this drug cannot be used in emergency cases, as it has no immediate effect, because it is taking 4 to 5 days. So it is only used as maintenance anticoagulant. So this is important. Warfarin is only preferred in the maintenance treatment. It is mainly used in the maintenance treatment. Getting a point? Okay. Now the most important point which I need to mention, very very important. Look here. During initial 5 days, okay, during initial 5 days, we are seeing here protein C is also getting deficient. So due to protein C and protein S deficiency, and protein C and protein S are anticoagulant factors. Remember this, protein C and protein S are anticoagulant. So during initial 5 days, protein C and protein S will be deficient, and that will increase coagulation, because they are anticoagulant. Because of their anticoagulant property and their deficiency in initial 5 days, they are going to increase coagulation, and that can lead to skin, limb, adipose, breast necrosis, and for the treatment will be amputation, which is very dangerous condition. So in initial 5 days, warfarin is combined with heparin, and that is known as heparin bridging. Remember this, is known as heparin bridging. Clear? So this concept is very very important. Now coming to the properties of warfarin. So oral dose is given, that is 1 to 10 milligram per day, 99% albumin bound here. It means there will be low volume distribution, but due to high albumin bound, there is no role of hemodialysis in its toxicity. Then warfarin basically is a racemic mixture of R form and S form. That is not important. Now coming to the most important point, that is warfarin interaction. So some drugs can decrease the activity of warfarin, and some may increase the activity of warfarin. So CIP enzyme inducer, basically, which are the inducers of CIP enzymes such as rifampicin, this will decrease the effect of warfarin because it will increase the metabolism of warfarin. Estrogen, because what is the mechanism of estrogen? Estrogen increases the formation of your clotting factor 2, 7, 9 and 10. So by increasing clotting factor 2, 7, 9 and 10, this estrogen can cause therapeutic failure of warfarin. Then in nephrotic syndrome, and because in nephrotic syndrome protein already getting lost from your body. Clear? So this will decrease the effect of warfarin. Clear? Warfarin will be getting lost from your body. So in nephrotic syndrome, this because albumin, and with 99% it bounds to albumin, so albumin, and with it warfarin is lost from your body. So these three CIP inducers such as rifampicin, then estrogen, and then nephrotic syndrome, these three will down regulate the effect of warfarin. Then what will increase the toxicity of warfarin? So enzyme inhibitors such as coke, we have used trick, cimetidine, ketoconazole, like this. Then antimicrobials such as cephalosporins, and then aspirin. This will increase toxicity of warfarin, because antimicrobials will inhibit your gut flora, okay, normal gut flora, which is synthesizing vitamin K. So gut microbes help in vitamin K absorption. So antimicrobials decreases the vitamin K absorption as well. So it is inhibiting vitamin K, as well as here is decrement from vitamin A. So it will increase the toxicity of warfarin. Now T half is 20 to 50 hours. Okay, this drug also has narrow therapeutic index, so there is a requirement for therapeutic drug monitoring. So we measure generally PT plus INR. Clear? Okay, we do not generally prefer TDM, we directly measure PT plus INR. Now what is INR? So INR is PT of a patient, which is compared with a PT of laboratory, or a standard PT, or normal PT basically, and to the power ISI. And normal value of INR, it should be always less than 1.1. What is this ISI? ISI is International Sensitivity Index, which is depend on the method by which you are performing PT. Clear? Now coming to the uses of warfarin. On the basis of INR, we determine the uses of warfarin and management of warfarin overdose. So on the basis of INR, we are adjusting these two things. Okay. On the basis of INR, we are adjusting these two uses of warfarin, where warfarin can be used, and the second is management of warfarin overdose. So first coming to the uses of warfarin. So if INR value is 2 to 2.5, then it is used for the prophylaxis of DVT or pulmonary embolism. If 2.5 to 3, then treatment of DVT or pulmonary embolism. If 3 to 3.5, then recurrent DVTP, means it can be also used for atrial fibrillation plus mitral stenosis. Now coming to the most important part, that is management of morphine overdose. This is generally asked in your short notes in your semester examination. What is the management of warfarin overdose? Clear? So management is basically based on two things. Suppose there is no bleeding, means patient is asymptomatic with increased INR. INR is increased, but patient is asymptomatic. Here bleeding is there. If bleeding is there, then we will not look on the value of INR. Any value of INR. If bleeding is there, then it will be treated like this. There is no requirement for measuring INR. If there is no bleeding, means asymptomatic, then we have to look INR value. So if INR value is less than 5, then we have to stop warfarin. If 5 to 9, then vitamin K1 through oral route 2.5 mg we should give. Then if 9 to 20, then vitamin K1 oral dose 5 mg we should administer. And if more than 20, then vitamin K1 IV we should administer, that is 10 mg. So this is the management in asymptomatic patient. Now if bleeding is occurring, then we start with vitamin K1 IV 10 mg plus we also give fresh frozen plasma, that is 50 mg per kg. Clear? Now what are the side effects of warfarin? Very important. It causes bleeding. The most common side effect will be bleeding. Don't worry. Non-specific side effect is ADD, alopecia, dermatitis and diarrhea. ADD. Yeah, you can also remember like DAD. Dermatitis, alopecia and diarrhea. Then it also causes purple toe syndrome, that is cholesterol emboli. And this drug should be stopped 4 days before surgery to reduce the risk of bleeding. Aspirin was stopped 7 days before. This drug should be stopped 4 days before surgery. What is the contraindication of this drug? So pregnancy is the contraindication. In first trimester, it may be teratogenic and it causes generally fetal warfarin syndrome, which is characterized by saddle nose, limb hypoplasia and microcephaly. These are the characteristic finding in your fetal warfarin syndrome. Saddle nose, limb hypoplasia and microcephaly. Then what will be the drug of choice in pregnancy? So low molecular weight heparin, the drug of choice in pregnancy. Clear? Now what are the anticoagulant which can be used in pregnancy? So for 1 to 12 weeks, drug of choice will be low molecular weight heparin. 12 to 36 weeks, drug of choice will be warfarin. 36 weeks to 1 day before delivery, low molecular weight heparin. Clear? So this is about your warfarin. In next video we will discuss about the next part of anticoagulant, because it is a long part. Okay, so in next video we will discuss. So thank you for watching. Best of luck. Bye bye.